so she will go. Then we will start the other ones.
A very good morning, all the dignitaries. Uh, I would be speaking on management of corneal trauma for general ophthalmologists. I am Dr. Vijayalakshmi. I am working as assistant professor in Osmania Medical College. We'll be looking at the approach to a patient of trauma, classification of injuries, what can you manage and what can you refer, and do's and don'ts in the trauma patient. And how do you do this follow up of the trauma patients? Generally, this is the way patients present to you in casualty. It's very important to see the patient in toto. It's just not the eye. Though we are concentrated as ophthalmologists, this was the injury of the patient when the bandage was removed. Such a bad injury. He had a machine injury where his frontal bone and the forehead was all cut because of the machine. So it's important to look at the patient in toto. Life threatening and limb threatening injuries are a priority always. Whenever you're taking a history, it's very important when you see that injury patient, you have to make sure that you take the history along with seeing the patient. So always ask for history of loss of consciousness, history of nasal bleeding, history of ear bleed, injury to the limbs, any history of blunt or penetrating trauma, and injury to the head. Few important points to note are: what is the mechanism of the injury, what is the timing of the injury, is there any IOFB suspected in the mechanism of the injury, and if so, what is the type, past medical history, and previous ocular surgeries, current and past ocular medications, and vision in the eye prior to the injury, and what is his tetanus toxoid status. So Birmingham eye trauma terminology has given few important terminologies which will go ahead. So open globe injury can be divided into rupture, in which this is an open globe injury caused by a blunt trauma, and there is a laceration where is the full thickness defect in the cornea and the sclera, or it might be when it's only the entry wound, it's a penetrating, and when there is entry and exit wound, it's perforating, and when there is an IOFP, you grade it as IOFP. You have to know about the zone of the injury also, which will help you to prognosticate also. Zone 1 is the injury limited to the cornea. Zone 2 is injury limited up to the 5 mm of sclera, and anything beyond is zone 3. Grade of the injury will vary from 1 to 5, ranging from having a vision more than 20/40 to no PL. Pupil, you have to look at the RAPD and grade the patient as pupil positive and negative, and this is same for both the closed and open globe injuries. Now, in case of closed globe injuries, zone 1 is the outer wall, that is the conjunctiva and the conjunctiva and cornea, but it is not entering into the anterior chamber. There is no full thickness defect. Zone 2 is anything up to the posterior lens capsule, and zone 3 is anything beyond that. There are different types of closed globe injuries like the contusions, lamellar lacerations, which are not deep into it, and superficial foreign bodies, and mixed. Again, the grading is similar to that of open globe injuries, varying from 20/40 to no PL. So there is something called as an ocular trauma score, which will help you to slightly prognosticate what would be the vision of the patient outcome. So initially, based on the vision and all the other coexisting factors, he is given a score, and then because of the based on the score, we can just prognosticate how his visual acuity will be at the period of 6 months. So just to reiterate, this is the most important thing which you have to know: whether it's a closed globe injury, it's a superficial where the cornea sclera are intact; open globe injury where is a breach in the full thickness of the cornea or sclera. Imaging is an important modality in ocular trauma. We use a CT scan, MRI, or an X-ray according to the purpose. Generally, magnetic foreign bodies we avoid MRI, and in pregnant ladies also we avoid CT scan. So whenever there is a penetrating trauma, you look at the history and you see any foreign body which is going deep, you just take the patient to the OR and remove it in the OR and probably put a suture along with it. If there is no foreign body which is obviously seen, then do a full eye examination, look for any lid laceration, rule out any canalicular injuries. If there is nothing like that, you can look for corneal lacerations. Always do a Seedles test, and if at all Seedles is positive, you have to go ahead with the corneal tear repair. In case you are suspecting any IOFP, just make sure if it's metallic. If it's metallic, you can go ahead with a CT scan and then plan for a removal in OR. And vegetative, when it's vegetative, you better go for an MRI and removal in the OR. When it's a blunt eye trauma, you have to ask for the history. History is the most important thing which will guide you towards what might have happened. If it's a globe rupture, you have to shift the patient to OR. That is because you have to suture it. Then look for any proptosis. If there is a proptosis, is probably even if the globe is intact, it's probably a retrobulbar hematoma. Maybe you will need a B scan or a CT scan, and you will have to do a lateral canthotomy. Then if there is no proptosis, look for the entrapment of the extraocular muscles. If there is entrapment of the extraocular muscles, then you would go for a CT scan to rule out any orbital fractures. Orbital fractures are usually delayed primary, are done with either primary or delayed repair. If there is no entrapment of the pupillary extraocular muscles, just check for the abnormality, structural abnormality of the pupil, as you are seeing any traumatic miosis or mydriasis, and you have to treat accordingly. And check also for RAPD. If RAPD is present, you have to always suspect an optic nerve injury, large retinal tear, or a vitreous injury. So a detailed examination is mandatory. And then look for the anterior chamber. If there is hyphema, maybe treat accordingly. If there is abnormal vision, look for cataract, dislocated lens, or a retinal detachment. Always check for the IOP, because there might be some hemorrhage in the globe which is causing a high IOP or a rupture. If it is low, then always suspect a low ruptured globe and always go for a wound exploration. So in case of a open globe injury, for a general ophthalmologist, always place a shield, prognosticate the patient. That is very important. And later in other talks, you will be knowing about the management tips of the corneal tear repair. Always avoid using any topical drops in an open globe injury, and start the patient on broad spectrum IV antibiotics. So the important steps, just to reiterate again, you have to start the patient on IV antibiotics and strictly avoid topical drops. So all cases you have to remember that you have to put them on long-term follow-up, because these patients, especially with closed globe injuries, they recover, that hyphema and all is recovered, and the vision is also recovered, but they might have an angle recession or a peripheral peripheral retinal tears, which if missed might cause sight-threatening sequelae for the patient. So these are few of them. I'll quickly run through them. Just to tell you that a stitch in time always saves time. These are few of the patients which we have operated, and they are doing very well in the post-operative thing. And to summarize, it's important to differentiate between an open globe and a closed globe injuries, and prompt early treatment is very crucial in restoring the vision, and long-term follow-up of these cases is mandatory. Dilated fundus examination and gonioscopy is a must for all the closed globe injuries in the follow-up. And it is important to prognosticate the patient, tell the patient that the vision we cannot really predict. Most of them ask you what will happen to my vision, but it's important for you to tell that, we have to look at 2-3 months, probably only then we can say what type of how much of vision he might get. Thank you.
Thank you, Dr. Vijayalakshmi. Nicely presented. But only one thing, you have not saved yourself. Whenever a ocular trauma occurs, you must mention the identification mark and inform the police, whatever the condition may be. That you should not miss.
Yes.
In your first slide, you must write that identification mark and the
also
information.
A proper MLC has to be documented.
Yeah,
because
in history taking is also important. If that
Yes.
point also, they may be telling something wrong.
Yeah.
There may be a domestic violence. They will say, I will fall on the road or something like that. So that part you have to also find it out. So legal point you have missed. Only thing, please add in the next your speeches. So that is very vital for the ophthalmologist. Thank you.
One thing I like to add.
Yes.
Okay, we are skipping for as Silpi has to go somewhere. So we'll go for management of block perforation by Dr. Silpi. No. Soumya Peri? He has come. Anyone who wants to speak fast and go? Any flight? Hi.
Thank you for the consideration. So I'm speaking on the topic of globe perforation. So it can even happen in the experienced surgeon's hand. It is a very uncommon but recognized complication which is decreasing because now most of the surgeries are done under topicals. So the survey was done by the Royal College of Surgeons, and it has been seen that the 75% of the cases of block perforation, they occurs in the hands of the anesthetist, and they miss basically. And when we come to the ophthalmologist, the incidence is relatively equal between the residents and the consultants. So these are the various causes. Like it can be punctured during the posterior subtenance injection, subconjunctival injection of the gentamicin or the dexamethasone at the end of the surgery. Most common is the peribulbar anesthesia, and in this the most common quadrant involved is the superionasal quadrant. The other causes that while doing the suturing during the RD surgeries and scleral tunnel. So what are the predisposing factors? The most common predisposing factor is the elongated eyeball, that is myopia, post-retinal detachment surgery, especially after the buccal surgeries, in deep-set eyes, severe enophthalmos, and a very uncooperative patient. So these are two stages of perforation. The first stage, the penetration is only there and damage occurs because of the sudden rise of the IOP, which can cause central retinal artery occlusion or the cloudy cornea. And if the drug is injected within the eye, then the vision is lost because of the toxicity of the drug. The second stage is double penetration, that is called perforation. It is missed in more than 50% of the cases, and the surgeon or the block given people is not aware that they have done this complication, and the vision loss is because of the vitreous hemorrhage, subretinal hemorrhage, or the retinal detachment. So what are the characteristics of the breaks? The most common site is inferotemporal or superionasal. It can be in two shapes, like multiple swing machine shape, which is close to each other, or the oval shape. It is two separated in opposite meridians. It happens when we give the block multiple times, like in two different quadrants. Presentation, it can be sudden because of the pain or the hypotony, and there is sudden loss of vision. Usually it is seen on the first post-operative day if it is missed, and it is because of the vitreous hemorrhage, hypotony, diminution of the vision, and the hyphema which we see. So what are the signs of the perforation if vitrectomy is performed in such cases? You see the puckered scleral scar or a choroidal scar which is caused by the needle track, and yes, the two types of breaks I have already explained. So the prognosis is, early you detect and manage these cases, better is the prognosis, because injected drugs, they cause retinal toxicity, so they need to be managed accordingly, and there are less chances of PVR if anyhow the RD is caused because of that. So if only there is a break and no subclinical RD, you can just do a barrage laser and the case is done. But if you see that there is a break along with subclinical RD, you can do the laser and a pneumoretinopexy, and we'll see that there is a good response to that and you don't need any further surgery in such cases. Just remember, always defer the surgery if you are planning a cataract surgery or this, if the media is clear. Vitrectomy is done, if earlier it is done, it is better, and it's worked by the mechanism that it removes the toxic intraocular contents which are injected during the perforation. It prevents severe proliferative vitreoretinopathy, and it also removes the scaffold. So this is a case which was referred to us as a case of a suspected globe perforation, and the surgery was deferred. So in this case, the phaco was done. There was no glow because of the vitreous hemorrhage. After doing the phacoemulsification, the IOL was put, suture was taken, and 3-port pars plana vitrectomy was done. You can see that the vitreous cavity is full of vitreous hemorrhage in this case, and you can locate the break there. There is a very hazy view of the retina, but there was only a break and the vitreous hemorrhage. Retina was well attached, so only the laser was done to the break, and no tamponading agent was used in this case. Now this is the another case which presented with retinal detachment. So after clearing the vitreous hemorrhage, you can see there is a slit-like break over the macular region, one break here and one more break here. So this was a case of multiple punctures, and you can also see the track which is going from the choroidal tissue. So after removing all the blood, removing all the traction, routine retinal detachment surgery was done and the tamponating agent was put as a silicone oil in this case. Now the last case of this was the case of retinal detachment with severe PVR and with full thickness macular hole. Full thickness macular hole may be a coincidental finding in this case. You can clearly see the break there. So after doing the thorough vitrectomy and removing all the membranes, the ileum was stained and peeled off and the membranes were peeled in the periphery. PFCL was put and the case was closed after the tamponating agent, put the oil as a tamponating agent. So to conclude, it is a rare complication, but if early diagnosed, it can be managed easily and we can prevent the complications like retinal detachment and severe PVR. So one should always suspect that if the globe perforation has happened, they should stop the surgery and refer the patient for the same at the earliest. Thank you.
Thank you, Sylvie. Nicely presented, but the key point is only early diagnosis. The more quickly you know you have perforated the globes, you can stop the surgery and refer it. That is the only point you have to highlight.
Yes.
Thank you.
Sometimes on the same day itself.
Some day, some hour, we can be done.
If you feel that it's hypotonic while doing the surgery, then
Before don't do surgery.
Yes.
Only thing
We
once
do
you have
before the surgery.
before the surgery.
Yes.
Before the surgery.
Yes. Yes.
The moment you suspect, defer the surgery.
Yes.
That is the key point of
Key
this
point
note.
of this.
itself an indirect ophthalmoscopy can be done to see the.
Thank you. Thank you, Sylvie. Next. Yes, Somya.
Child's play, after all, pearls in the early diagnosis and management of pediatric ocular trauma. It's not playing. Okay, so the objectives being we need to segregate what can be fixed in the emergency department and what requires OPD management. The challenges being the child is in pain, unwilling to be examined, anxious parents and doctors too, unclear history, unwitnessed trauma. So take as much history as possible. No forceful examination of the child. EUA may be necessary. So coming to ocular examination, it's very essential. Always do ocular examination of the affected eye also and the unaffected eye also. Take ocular examination, visual acuity record by Snell lens or e-chart if feasible, and check the eye movement in all directions because we need to eliminate any chances of any diplopia or muscle entrapment. So EOM movement should be checked in all directions. It's very important. Visual field should be checked in all 4 quadrants. Pupillary reaction, both of the direct reflex and the consensual reflex should be recorded. RAPD, if present, should be documented. So as we know that males are more prone for any ocular injuries as they are more seen in outdoor activities and childhood labor. So coming to the injuries to the lids and adnexa, ecchymosis of the lids, secondary ptosis due to hematoma are seen. Cold compresses of the initial 24 hours is very essential. Lid suturing edge-to-edge closure is very important. Self-absorbing vicryl sutures should be substituted for the margins as it is difficult to remove the sutures without additional anesthesia in children. So involvement of the medial 1/3 canalicular injury, lid margin, tarsal plate, LPS muscle ptosis needs immediate intervention. So coming to corneoscleral lacerations, this will be covered later in detail. So surgical management depends upon the type and extent of the injury. Primary goal being watertight closure and restoration of the structural integrity. Secondary goal being restoration of the normal anatomy and removing any vitreous or uveal tissue from the wound. Foreign body, if present, should be removed and documented. General anesthesia is preferred in children. Avoid any pressure on the group and use sterile BSS to remove any ocular debris from the surgical field area. So tear involving the visual axis is sutured with small suture bites in the center and longer bites in the periphery of the cornea. So when we remove the sutures, it will induce a uniform astigmatism by Rousseau-Hay technique. So suturing of the vertical and shelf wounds, it should be usually 1.5 mm in length, 90% in depth, and entry and exit wound should be perpendicular to the surface of the cornea, and it's essential to oppose the internal edge rather than the external edges, preferably by interrupted sutures. As shallow suturing can cause wound gape, unequal depth of suture, wound override, and full thickness can lead to microbial entry. So this is one of our cases of corneoscleral tear which was successfully managed, giving good visual acuity to the child. So the key points being have a good follow-up, examine for loose sutures, suture infiltrates, and remove the sutures after 6 weeks. Ideally, remove the sutures from the steeper axis first and examine the other eye for sympathetic ophthalmic matters. So white-head fractures are a subgroup of fractures which are seen in patients less than 18 years of age with little visible external soft tissue injuries, and it usually affects the orbital floor. So acute incarceration of the herniated tissue in a trapdoor effect occurs due to greater elasticity of bones in younger people. CT features may be subtle, and indications of surgery being entrap muscle diplopia, anophthalmos, CSF leak within 24 hours. You can observe if above indications are not present, and always tell the patients to avoid blowing their nose. So globe ruptures are very essential to be done surgery in the first come first served basis. So the mechanism of injury being blunt, penetrating or perforating objects, conjunctival lacerations if they are present greater than 6 mm should be sutured with 60 vicryl. So in cases of occult scleral rupture or scleral tears, and in this case as we can see it is a corneal scleral tear, the principles of suturing being always secure your limbal sutures first, followed by the sclera and then the cornea. So it's always LSC pattern that we need to follow. So after securing your limbal sutures, for the scleral sutures, do a limited peritomy and always explore the wound. Wound exploration is very important to remove any foreign bodies if it is there, and always oppose the anterior and posterior edge of the sclera with 70 vicryl till the posterior limit of sclera which is visible. So traumatic hyphema in children, it's due to tear in the anterior ciliary body which causes bleeding in the anterior chamber, which can be managed by elevation of the head end of the bed, eye shield, decrease IOP, topical or systemic antifibrinolytic agents, and topical and systemic steroids. So coming to traumatic cataract, only traumatic cataracts with ruptured anterior capsule, we can plan cataract surgery with or without anterior vitrectomies. So in traumatic cataracts with corneal perforations, always suture the corneal tear first. Then plan the cataract surgery as a secondary procedure after the corneal wound healing is complete, say after 4 to 6 weeks. Keratometry reading of the other eye is preferred as there will be scarring of the affected eye. Primary posterior capsular rhexis is mandatory for all traumatic cataracts as there is high chances of membrane formation in these children. So 3-piece or rigid IOL is preferable to foldable IOL, and intensive topical steroid should be given in the immediate postoperative regimen. So in this example, as we can see, the corneal tear has been nicely secured first, and we planned for the suture removal after 6 weeks, and then appropriate keratometry readings were taken and IOL power calculation was done, and we planned for the traumatic cataract surgery, and the IOL implantation was done for the patient after 3 months, and this led to good visual restoration of the patient. So if any bacterial endophthalmitis is there due to trauma, it has to be managed on an urgent basis. Counseling the parents and children about the poor prognosis is important. Posterior segment injuries like commotio retina pustules, whiplash injury, traumatic rhegmatogenous RD and all have a very poor prognosis, and counseling the parents and child about the guarded visual prognosis is important. Traumatic optic neuropathy occurs in the age of 12 to 16, causing 3rd, 4th and 6th nerve paralysis. So doing an MRI, referring to the neurologist, and counseling and reassurance of the parent and child is very important. Retrobulbar mass caused due to retrobulbar hemorrhage. It basically causes a rapidly increasing retrobulbar mass due to blunt or penetrating trauma, which should be managed by IV mannitol, IV steroids, acetazolamide and lateral cantothermy. So for intraocular foreign body, as madam has highlighted before, the investigations play a very important role. So before planning for any pediatric ocular surgery, you should always keep the patient elbow out for 6 hours. To have an empty stomach and potential airway problems can also be avoided. And always take the anesthesia clearance, and if possible, always operate with anesthetist. So the take-home message being, most of the injuries sustained in workplaces can be avoided by discouraging child labor or by wearing protective gear in workplaces. Activities such as fireworks should be done under proper supervision, and better healthcare facilities should be provided in rural areas so that delay in seek-off treatment is best avoided. Thank you.
Thank you, Soma. But as usual, you have missed the legal points. You have not taken the consent from the parents.
Yes.
That is very important. Whenever preparing the next time, when you are going to talk,
Sure, sir.
identification marks, type of injury, and the consent.
Yes, sir.
Take a slide that the consent has to be very important.
Okay.
Thank you. We are running
you, sir.
sort of time. So next, you will go. Okay, thank you. Okay, thank you. Canalicular laceration, Sonia Fulke. After Sonia Fulke, Dr. Sumita Mahapatra.
Department of Ophthalmology from Mohali Medical College. So I'll be discussing about the canalicular lacerations and management. Just few minutes to start. Lacerations and management. So if we see some kind of periocular injury, so these are the canalicular lacerations are the most common type of lacrimal injury other than punctum, other than lacrimal sac or the NLD. So varied presentation, if we go by the literature, we can say that they are present in approximately 17% of the eyelid trauma. They have varied presentation, and lower canaliculus is most commonly involved rather than upper canalicular or the bicanalicular. Okay, so mechanism and modes of injury basically depends upon the age of the patient. In infants, it is usually caused by the trauma by the hook of the blouse of the mother, and with the history of fall from the staircase and all. But in adults, it is usually seen by the roadside accident or by the blunt trauma and all. So mostly if we see the pure medial side of the injury, medial side of the ocular injury, we should always suspect the canalicular laceration, because most of the time they do not have any kind of tissue loss. So always you should look the patient under the slit lamp or under the high magnification to rule this kind of canalicular laceration and injuries. Okay. So why do we want to treat these lacerations? Of course, we have to prevent the stenosis, which can ultimately lead to formation of development of epiphora. And yes, cosmetic is also important for the patient. And now coming to the cardinal rules for this kind of trauma management, just like other trauma management in the eye and in the surgery part, we need to take proper history. We have to document whether the patient is having any kind of roadside accident. Then we have to document the MLCS sir has emphasized earlier also. Then we need to do the thorough eye examination, including visual acuity, fundus, and very important to assess the globe. Globe assessment is very important because sometimes we miss the globe injury. We just suspect that the patient is having only the periocular injury, but periorbital or periocular injury, but we need to rule out the globe injury also. Then of course, in cases where we are suspecting foreign body or any kind of fracture, so we need to order the radiological studies also. Then what are the timing of repair? This is very important to understand, because the primary repair, which has to be done within 2 days, that ensures the best possible repair. So this needs to be done within 2 days. That is recommended. Okay, secondary repair is also indicated when the patient is systemically unstable, when the patient is having very infective wound, and when we want to resolve the cicatricial changes that has resulted from either the initial trauma or from the subsequent surgical repair. So we can defer the patient for the secondary repair also in these special conditions. Otherwise, primary repair is always indicated. Now, what are the principles to operate or manage this canalicular laceration? So first of all, we have to identify the cut ends medial as well as the lateral ends. Then we have to approximate those cut ends, and then we have to do the stenting. Then retention of the stent is for adequate period of the time is required, and usually we allow the stent to remain for approximately 3 to 4 months. And then we have to close the laceration properly in layer by layer. Then if the patient is having both sides of the canalicular laceration, then of course you have to repair both canaliculi, right? Then this one is the most important slide. How do we find the torn end? So of course the lateral end is very easy to find. When we see under the microscope or under the high illumination or magnification, you can easily identify the lateral end. The most important problem happens with the medial end. So I'll just cover the medial end topic. Then the first is we need to see under the good illumination and under high magnification. That is the most important. Then you can identify the medial end. Then the pictorial probe is always a savior. But the problem is that pictorial probe is mostly not available in the emergency. So then the other methods like injection of dye or viscoelastic substance through the opposite punctum and air injection. But these last two methods are always like, it depends upon your assistant actually, how much they are putting pressure over the lacrimal sac. over the how much if they are not able to put the pressure over the lacrimal sac, then this method could be failed. So first to this examination under illumination, and the pictal probe is always like, this is my one of my favorite, these always help. Now coming to the stents. So we have different types of stents. We can use the monocanalicular stent, we can use the bicanalicular stent, and material of choice is always mostly silicone, because they are inert, inactive substance. Then coming to the monocanalicular stent. So most commonly available in the market is the mini monoca, and if we do not have this mini monoca, then IV intracat cannula can also be used as the monocanalicular stent. Then we have the bicanalicular intubation set like Crawford and Ritling. Ritling, I'm not sure it's available in the India or not, but Crawford is always available, and it costs approximately 3,500 only. Then a brief discussion about this mini monoca stent. I think all of us are aware about this mini monoca stent. It has a peculiar, hole kind of thing here. So the post-operatively patient does not have any kind of epiphora, because this kind of hollow lumen, it allows the drainage of tears from punctum to the sac area. So the most important advantage of this mini monoca is that patient is not having any kind of epiphora. Second, it does not require any kind of suture. Like if you put the IV cannula as a canalicular stent, then you have to secure it with the suture, so it can cause the irritation to the patient post-operatively. And as well as in the bicanalicular, if you use that bicanalicular stent, then also patient can have the irritation. So these are the most common two advantage of mini monoca stent or monocanalicular stent. Then coming to the short video, this is the patient of 40 years age. This was operated. He is having distal canalicular laceration. So here we easily identify the lateral end. Now we are trying to identify the medial end, and then here we are using the Crawford stent. So this Crawford stent is having a tip which is olive, and it is blunt. It is not very sharp. So it does not hamper, it does not traumatize the sac or the NLD. So it easily go. Then you have to secure the stent from the nose. So it goes from the lower injured canalicular part first, and then from the upper punctum the other end of the stent has been passed, and then now it is going to be secured. The stent is always like we have to remove after 3 to 4 months. Okay, so this is the pre-op patient, and this is the post-op patient of the same patient. Then what are the complications? Complications are just like other implants. It can also self-extrude, and they can cause the punctum ectropion. They can cause the splitting also, and false path is not usually reported. But monocanalicular stent, they can have a 13% chances of self-extrusion, and then here you can see that the patient was operated 2 days back, and then this stent has come out from this side. Then patient can have a granuloma formation in more or less 3% of the cases. Now, this is just my experience. Then when the patient is having proximal canalicular injury, then you can measure it with the probe. Proximal means when the patient is having almost 3 mm or less than 3 mm injury, then you can always use monocanalicular stent. They works well. And when you are very much pretty sure about the distal or medial torn end of the canaliculum, then it is preferable to use monocanalicular stent. And when the patient is having a distal canalicular laceration, like the patient is having crushed injuries, like you are suspecting patient is having a very much a lacerated wound over near the sac area. In those cases, we prefer to use bicanalicular stent. But mostly it depends upon the surgeon's choice. Now, what is the take-home message for this discussion? The success rate of canalicular repair is 90%. Primary repair with stenting increases the success rate. Early appropriate diagnosis and surgical techniques can avoid or minimize several complications due to canalicular trauma. Thank you.
Thank you, Sonia. Really, it is difficult to adjust the medial end in the canalicular process, and the complaint goes on watering and everything. So that part is taken out very nicely. Thank you, Sonia.
Thank you, sir.
Now we are going to for the traumatic glaucoma by Prerna. Prinnan Gaur.
Good morning, everyone. I'll be giving a talk on traumatic glaucoma. I am a glaucoma consultant working at Shroff Charity Eye Hospital in Delhi. So the risk factors which predict the development of traumatic glaucoma are different for closed globe and open globe. The incidence of traumatic glaucoma is more in closed globe injury as around 3.39% as compared to 2.67% in an open globe. And the risk factors include an elderly patient when the baseline visual acuity is less than 6 by 60, when the baseline IOP is high, if the patient has presented with hyphema, angle recession of more than 180 degrees, presence of an iris injury or lens injury. And in open globe, the glaucoma is more common after penetrating injuries in case of a adherent glaucoma or a lens injury or displacement. So we all know in a closed globe injury, it occurs when there's something when it hits the globe, which has a diameter larger than the globe diameter, and causes a momentary anatomic deformation of the globe, causing an anterior posterior shortening and an equatorial expansion. And this causes separation at 7 rings of the equator. And these 7 rings include, the first is the iris sphincter, which leads to the sphincter tears. Then there is the trabeculum, the iris base, which causes an iridodialysis. The anterior ciliary body leading to a split between the two layers of the ciliary muscle, causing an angle recession. The ciliary body to the scleral spur, causing a cyclodialysis cleft. Then tears in the trabecular meshwork can occur. And then there are, the sixth is the zonules, causing a lens subluxation or dislocation. And last is the attachment of the retina to the ora serrata, leading to a retinal detachment or dialysis. So what are the causes of IOP elevation? They can occur in the early stage when the patient is presenting to us within 1 month of trauma, or after that. In the early onset, the most common causes are trabeculitis and uveitis, which account for 20% of the cases, and treatment is basically by steroids and cycloplegics and anti-glaucoma medications. The second is the trabecular disruption, which has been noted to occur particularly with this airsoft gun, which was used earlier, not in India but in Japan and US. And with these plastic pellets, when they hit the globe, it was found that it caused trabecular meshwork tears. So this slight amount of bleeding can be seen, which is confirmed on UBM by this structure, absence of this trabecular meshwork. So they appear either as shredded iris processes or a flap at the scleral spur. The third is the hyphema, which is an important cause of IOP rise in the early period, and the risk of increase in IOP increases to as high as 50% if it's a total 8-ball hyphema, and in grade 3 it's 27%. There are multiple causes which can occur either because of an associated contusion or inflammation of the trabecular meshwork, or a physical disruption of the trabecular meshwork, plugging of the TM with the red blood cells, or a large clot in the antechamber causing a pupillary block. A rare cause is a massive choroidal hemorrhage, which can occur following either a choroidal rupture or tearing of the long or short posterior ciliary arteries due to the deceleration forces of the trauma, and usually it resolves spontaneously with oral steroids and topical steroids and AGMs, but sometimes a drainage is required. Coming to the causes of delayed onset traumatic glaucoma in a closed globe injury, the most common is angle recession. So normally we do gonioscopy, if there's a patient with hyphema, we do gonioscopy after 1 to 2 weeks once the hyphema has resolved. And angle recession can be seen on UBM, similar to this, where we can see that there's a split between the two circular and the longitudinal fibers of the ciliary muscle, giving the appearance of a widened CBB on the gonioscopy. And when there's a patient with hyphema and we do a gonioscopy, in 70 to 100% of patients, angle recession will be there. However, the glaucoma occurs only in 7 to 9% of patients, because it has been seen histopathologically that in patients with angle recession, there is fibrosis of the trabecular meshwork, which accounts for this glaucoma, and it can occur even 10 years after the trauma. So these patients with particularly more than 180 degrees of angle recession require a lifelong, long-term follow-up. And it is important to examine the other eye, because Speth et al. Noted that patients who presented with glaucoma in one eye, 50% had glaucoma in the had a dys suspect or glaucoma suspect in the other eye, so they are inherently predisposed to developing this glaucoma. This clinical picture shows a presence of an angle recession, which is the widened CBB, along with the cyclodialysis cleft, which is also present. So the treatment is medical. SLT can be tried in these patients. Trabeculectomy also plays a very good role if the eye is not very inflamed and conjunctiva is not scarred, which is usually not. It has a high success rate of around 8 to 90% in 1 year. GDDs also have a good success rate of around 90%. Then peripheral anticyanic can form and be a late cause of IOP rise, either because of organization of the blood or inflammatory debris. And if there's persistent hyphema for more than 8 days, can be associated with peripheral anticyanic formation. A rare cause of delayed IOP increase is a host cell glaucoma, which occurs particularly when there's a large amount of vitreous hemorrhage and blood clot in the vitreous, which leads to degeneration of these cells and loss of the intracellular hemoglobin, and they tend to leak in the anterior chamber and obstruct the angle because of the rigid nature. So it occurs 1 to 3 months after the trauma. Treatment includes anterior chamber lavage with or without a partial vitrectomy to clear the vitreous hemorrhage, and glaucoma surgery if required. And histopathology can be done of the anterior chamber lavage which has been done. Causes of lens-induced lens dislocation can cause either an anterior or posterior dislocation leading to a pupillary block, or a lens swelling phacomorphic glaucoma can occur, the treatment is usually to relieve the pupillary block first by PI followed by lensectomy. If it's a phacolytic glaucoma in which there is micro ruptures in the anterior lens capsule causing leakage of the high molecular weight proteins, it presents like this. Or if there's a rupture of the anterior lens capsule, it leads to leakage of the lens cortex, and all this occludes the trabecular meshwork. Treatment is decreasing the inflammation and the IOP followed by lens extraction. Then there can be delayed closure of the cyclodialysis cleft, and rhegmatogenous RD can be responsible for increase in intraocular pressure in few cases. Coming to the open globe injuries, the risk is 2.67% for developing glaucoma. There are the risk factors, a few are similar, like advancing age, presence of hyphema, lens injury, zone 2 injury, presence of vitreous hemorrhage, lens dislocation, presence of an intraocular foreign body, and there can be different causes depending on the stage. Two things which I would want to discuss is the sidrotic glaucoma, which occurs when there is retention of an iron-containing foreign body. So there's fibrosclerosis of the trabecular meshwork, presenting with iris heterochromia, mydriasis, a rust-like discoloration of the anterior chamber structures, night blindness, and reduced ERG responses. And mainstays treatment is removal of the intraocular foreign body. Another is a hemosidrotic glaucoma, which presents similar to a sidrotic glaucoma but no intraocular foreign body. So it occurs because of release of iron from the hemoglobin from the lysed RBCs, and that gives a similar picture as a sidrotic glaucoma. Thank you.
Thank you, Prerna. We have back-to-back traumatic glaucoma, so we'll discuss after that.
Yes.
So next is Professor Sumita Mahapatra. Traumatic glaucoma, often overlooked entity in ocular trauma. Mehul Shah is not there. Bhavik Panchal. Okay. So technically this is the last talk. After that we can have a discussion.
Good afternoon, everyone. My talk has been made easy because of my previous speaker, Dr. Prerna. I am not going into detail of the ocular trauma. Only I am going why it should not be overlooked. It is an often overlooked entity in ocular trauma. Actually, this is a case of a 15-year-old boy who sustained injury 5 years back by falling on the stone, but he got admitted to the local hospital and got treatment. He was told that there was bleeding inside his eye and said he should take rest. After rest also, he got his symptom got relieved and he was discharged, and he forgot about the incident. On and off he had some redness and watering from his eye, but he was okay till he got severe decrease in his vision and presented to us, and on examination we found that he has near total cupping and deep cupping. He has anterior subcapsular cataract. In gonioscopy we found that there was gross anterior angle recession of more than 270 degree, and there was gross thinning of the retinal nerve fiber layer. So this signifies that in ocular trauma we should not never underestimate the incidence of ocular trauma, traumatic glaucoma, because these patients, they get better and they do not have any symptom, but gradually the glaucoma process is increasing in them, which they do not know, and they are not doing. So proper counseling after any ocular trauma for even lifelong observation is important for them. So epidemiology, you can see that the incidence of glaucoma following blunt trauma at 6 months is 3.3 to 4%, but it increases to 10% after 10 years. It highlights the importance of the proper checkup and proper counseling. The ironically, it can be low following immediately after trauma because of the aqueous hyposecretion or increased outflow or tears in the trabecular meshwork due to either decreased secretion or increased outflow, but it doesn't mean that the patient will not have glaucoma in his future. So those patients also should be looked after. and there's the 7 ringer blonde trauma as described by Dr. Prerna, and all of these are injury indication that the patient had a severe ocular injury and should be followed up, and many of which can independently cause glaucoma. So early onset glaucoma have been described by her, and only thing is that I want to tell that intraocular inflammation and trabecular meshwork damage can cause glaucoma without the presence of angle recession or even without the presence of hyphema. So aqueous flare and aqueous cell also can cause glaucoma, but usually they are short-lived and they are self-limiting. So they only with topical steroids and cycloplegics they get cured. Then traumatic hyphema is also an indicator of significance of the ocular injury. It has been described beautifully by her, and the only thing is the susceptible of each optic nerve to level and duration of raised IOP. IOP may be raised for a longer time, or it may be has raised to a higher level. That is different, and how much one's optic nerve is able to sustain that raised intraocular pressure is different for anyone. So we cannot leave any patient that no, you are young, your optic nerve head and all. We can have to examine him periodically for development of the glaucoma. And traumatic hyphema in sickle cell need a special mention, because IOP elevation may be severe after accumulation of even small amount of blood in the antechamber, because sickle cells are very difficult to get drained, and they with a small amount of hemorrhage also they will cause high rise of intraocular pressure. Similarly, optic atrophy at lesser IOP level for sickle cell patient than the normal patient, because their optic nerve are already compromised due to the lack of blood supply due to the sickling, and carbonic anhydrides are contraindicated in them because they cause the systemic acidosis, which increases the sickling. So that those are the contraindicated. And secondary hemorrhage is a devastating complication of traumatic hyphema, which we should avoid. Usually it occurs between 2 to 6 days, and the chances of raised intraocular pressure and uncontrollable glaucoma is very much with them. And late onset of glaucoma, all these things are there. In the angle recession glaucoma, it is actually a misnomer, because angle recession itself does not cause glaucoma, only it indicates that how much damage has already been done, and so we should be following up those patients. And the incidence of glaucoma in case of angle recession is bimodal. Either it presents before 1 year or it presents at 10 years, because bimodal incidence, so we have to be very careful about the angle recession. And angle recession more than 180 is a major cause of secondary glaucoma, but we have to follow them, because after the incidence of the after the subsidence of the inflammation, the patient is happy, but we are not happy. And angle recession we can know by doing the gonioscopy. If in case of very subtle findings we may miss, and at that time it is a clue that we have to examine the other eye, and other eye we can see whether there is any broadening of the band or not, but that thing will give us a clue. And associated findings of other ocular trauma, associated findings of ocular trauma we should also look for, so that will give us a clue. Then traumatic lens-induced glaucoma is very common, as expressed by her, and out of that, lens subluxation is quite common. In a Chinese series of about 200 patients, almost 88% had lens subluxation dislocation. So that may be missed if you do not dilate the pupil. And the clue is that if on slit lamp we say one particular area of the iris is bulging, that means lens equator is disturbed and it is bulging. Dislocation we can see, but subluxation, if that is any tilt, we can see that way. And steroid response also should not underestimate, because usually frequently we give steroid to the patient to subside their inflammation, and if the patient is a high responder, then that can cause steroid glaucoma. And chemical injury also very common, and almost 11 to 22% of the ocular trauma is due to chemical injury only. Alkali is more dangerous than the acids, and IOP may be overlooked, because in the past picture you can see the cornea is totally hazy and our attention will go to the cornea, but after the cornea subsides, cornea clears, then we will forget, because that should not be overlooked also to see for the glaucoma. And evaluation, as I have discussed, ultrasound, UBM and specular microscopy, particularly late onset glaucoma with the downgrowth of the pupil can be known, and these are the findings, imaging of the cyclodialysis cleft and angle recession. Cyclodialysis rather than protective factor for developing the glaucoma, because that reduces the pressure. And by Ramajit Siota and all, these are the findings, and these are already been described by Dr. Prerna. And on UBM finding, wider angle and absence of cyclodialysis is a predictive factor for developing secondary glaucoma. So there are certain subtle signs we should not miss, there are, in the second picture you can see that there are micro tears in the sphincter, and that that gives a clue that there was hemorrhage. A hypema usually we do not miss, and if you see the dragging of the pupil to one side, that means there is injury to sphincter of that area, and we should be looking for the other signs of inflammation. And like I told, if you do not dilate the pupil, usually the pupil remains dilated in following trauma, we can miss the subluxation lens, and anterosubcapsular cataract is also not easy to be missed. So in the gonioscopy also, angle recession is a typical sign of angle recession glaucoma, and this finding you also should not be, if you see the pigments, comes of the pigments in the angle, then that is a sure sign that patient had previously ocular means traumatic hyphema, and that is a clue that patient may develop glaucoma. So to conclude, glaucoma may develop months to decades following trauma, so the patient should not be left as such, they should be properly counseled for frequent visit. This may go unrecognized because patient, in the meantime, patient will not have any symptom. Other sequelae of the injury after the trauma, it resolves, and appropriate counseling is very important. Like I told, everyone should be known that their patient is not free from any side effect, and it should be followed. And significant ocular trauma should be followed indefinitely, and all patients with glaucoma should have a careful history and complete examination to search for signs of glaucoma. History, it is important because that can give us a clue whether the patient has blunt injury or injury, if there is any chances of any retained foreign body or not. Suppose some iron foreign body may enter and the wound is sealed, we may miss, and that will give us a clue, and we should evaluate those patients for glaucoma. Thank you.
Thank you, Dr. Smita. Any questions from the audience? Anything? Any tips? Any other things? Anyone to give? We do have a little time. Yeah.
So one thing which I missed in my presentation was that especially for a patient, young, old, any patient is coming with unilateral glaucoma, and so unilateral, even POAG, PACG don't usually present as unilateral. Might be asymmetrical, but only a unilateral glaucoma with the other eye disc completely healthy, then it's very important to do gonioscopy in that. And in a lot of patients, we are going to see some amount of angle recession, and that can be a cause for the increase in intraocular pressure and the glaucoma in that eye. So especially in unilateral glaucoma, it's very important to do gonios. Like gonio has to be done in all, but some patients, we can identify traumatic glaucoma just by gonioscopy.
Glaucoma, but usually those are bilateral. If you do not see a single monocular involvement, and that is usually a secondary glaucoma, and you have to find the causes of secondary glaucoma. If you see in those subtle findings, then you can know that it may be traumatic glaucoma, and we have to give a prognosis accordingly. That is very important because we have to treat all the glaucomas, and giving the prognosis is very much important in case of traumatic glaucoma.
Okay. When there is a traumatic hyphema also, when you are thinking of the optic nerve damage, don't miss the blood staining of the cornea. If you are little late in treating those patients, there is a blood staining of the cornea, and that is a devastating thing. So when you are thinking of hyphema with the pressure and everything, you should take consideration of both points, optic nerve damage and blood staining of the cornea. Okay. Anyone? Any speaker who has not come late? No. Thank you. Thank you very much.
But before that, you have to exclude any globe perforation, and you should be sure that there is no globe perforation.
Thank you. Shall I request all the speakers to please come to the podium for a photograph? And we do have a good number of audiences. So after that, let the audience also come and have a photograph so that they should know that this session, some more people are there. Thank you.